Yes, hello. My name is Jesper Andersen, and I'm the head of the Andersen Group at the Biotech Research and Innovation Center at University of Copenhagen. I'd like to welcome you on behalf of myself and my co-chair to the FAST poster sessions. And Funda, over to you.
Hi, I'm Futibatineb. It's my honor to co-chair the meeting this year, and this is a very exciting year because we not only have posters, but we've introduced oral poster presentation session which are a little longer with discussion incorporated. We have 53 abstracts submitted this year, with 43 selected as posters. We had 6 reviewers, including a patient advocate this year. The poster sessions will be available through this interface till end of April, but they will be available long-term on the CCF website and on YouTube. During the sessions till April 30th, you can actually interact with the poster presenters and ask them questions through this format. We had 16 posters selected to be oral poster presenters, and today, we'll be reviewing the first half. 3 of these this year were selected for recognition awards, and this was so very difficult to decide. But I'd like to share with you our 3rd place poster winner, Lauren Stiggs, who you'll be hearing from today, who will be talking about modulating cholangiocarcinoma's tumor microenvironment. The 2nd place poster winner, who's Pashtun Kasi, who will be talking about longitudinal monitoring of actionable somatic alterations. And the 1st place poster winner, Meredith Mason, you'll be hearing from today to talk about upfront surgery and thinking the sort of strategy for resectable intrahepatic cholangiocarcinoma. With that, I'd like to congratulate the winners. This is really incredible. There's been a lot of great science submitted to the meeting this year, and really, I think a great opportunity for them to be able to present their work. So we'll go ahead and swiftly start with the oral abstract session. And our first presenter is Suichi Aoki from Japan, and will be presenting work on placental growth factor, promoting tumor desmoplasia and treatment resistance in intrahepatic cholangiocarcinoma. Today, everybody's going to be bringing up their own presentations, so that adds extra excitement to our session today, especially since it's April Fool's Day. So we'll see how that plays out. And you'll see one of the exciting things about today's presentations is that it really covers a large variety of topics, including immunotherapy and targeted therapy, looking at regional management questions as well as studying management questions. So we're hoping to hear from Lawrence about the immune environment today.
Lawrence, excuse me, you're on mute, sir.
Can you hear me now?
Yes.
Okay. Good afternoon, everyone, and thank you very much for the opportunity to present my work. My name is Lawrence Stiggs. I'm a former surgical oncology research fellow at the National Cancer Institute, and I'm currently completing my general surgery residency at Rutgers Robert Wood Johnson Medical School in New Brunswick, New Jersey. So I'm going to talk to you briefly about using a CD40 agonist to enhance response to checkpoint inhibitors, particularly anti-PD-1, in murine intrahepatic cholangiocarcinoma models. I have no disclosures. So a brief outline. So I'll give you a brief introduction, not so much on cholangiocarcinoma because I don't think anybody here needs that, and a little bit more about the role of immunotherapy in cholangiocarcinoma, and then tell you a little bit about the experimental background of my work and some of the exciting results that we've found in our lab. So briefly, cholangiocarcinoma, as we know, has a poor response to current systemic therapies, including the first-line chemotherapies, which are unfortunately most of the time ineffective. And so several groups have wondered whether or not there's a role for immune checkpoint inhibitors, particularly anti-PD-1.
Excuse me,
just
Lauren,
a brief, yes.
Can I see your slide advances? Can you put your slideshow in slideshow, please?
You cannot see it? Can you not see my slides?
It's not in slideshow, but we can see the one you're on currently now, so that's good.
Okay. So, yeah, just a brief reminder of the role of checkpoint inhibitors. So if you see here on the left, immune cells such as T cells can interact directly with tumor cells and can actually inhibit them or can result in their cell death. However, the interaction of PD-1, a receptor on T cells and other immune cells, with PD-L1, its ligand, can result in an inhibition of these effector functions. Drugs such as anti-PD-1 can inhibit this interaction between PD-1 and PD-L1, thereby allowing unhindered effector function of T cells against tumor cells. So at the National Cancer Institute, this was a small trial in which we looked at patients with cholangiocarcinoma, and we looked at whether or not these patients responded to anti-PD-1 after having failed standard of care therapy. And as we see, the results are quite disappointing. Half of the patients progressed and only one patient exhibited a partial response. So in the lab, I wanted to see whether or not this held true in our mouse models, because oftentimes what we see in patients is not necessarily what we see in mouse models. And I wanted to make sure that we had similar results before moving forward with any work with other immunotherapy molecules. And as you see on the right here, mice that were treated with a control IgG compared to mice treated with anti-PD-1 had similar survival, which was very much in sync with the findings of clinical trials, both at the NCI and elsewhere. So in our lab, we had come across in other studies the role of CD40 in liver malignancies and the role of CD40 in tumor immune surveillance within the liver. And so I wondered whether or not CD40 may have some implications in intrahepatic cholangiocarcinoma. We know that CD40 demonstrates anti-tumor activity. That's been demonstrated in several malignancies, and it can also reverse immune suppression. Particularly, it can facilitate the depletion of tumor stroma, which is quite relevant in malignancies such as cholangiocarcinoma. And it's also been shown to improve the effects and the efficacy of checkpoint inhibitors, particularly an early study that was discussed at AACR a couple of years ago, and that is ongoing, demonstrated that combining CD40 with PD-1 enhanced the response to chemotherapy, whereas that ending PD-1 alone did not. So just very briefly, this is a busy diagram, and I don't want to harp on it, but I just want to accentuate the fact that as we see here, the CD40 receptor on dendritic cells and other antigen-presenting cells can be bound by the ligand that's found on CD4 cells as well as on other cells, and this interaction results in a downstream activation both of antigen-presenting cells and, more importantly, of effector cells in the downstream immune pathway. So I wondered first whether or not CD40 did play a role in human cholangiocarcinoma. So we stained a number of samples, of human samples of cholangiocarcinoma for CD40 and found that it was very highly expressed on macrophages within these tumors. and looking at a database of Asian patients with, it's the Tiger database of Asian patients with cholangiocarcinoma. I looked at whether or not expression of CD40 within the tumor was associated with any sort of survival benefit. And interestingly enough, those who expressed high amounts of CD40 had a significant survival advantage over those with low CD40. So that just all that told me was that this was worth looking more into. And the next thing I needed to know was whether or not this held true again in mice in order to be able to move forward with our cholangiocarcinoma models. And again, we stained murine tumors, cholangiocarcinoma tumors for CD40, and we did find a high expression. And interestingly, when we look at the expression of CD40, it somewhat coincides with the expression of IBA1 and CD11C, which are markers for macrophages and dendritic cells, respectively. So kind of going back to the idea that that our antigen-presenting cells are highly expressive in CD40 within these tumors. So the next thing we wanted to do was test whether or not CD40 had an effect in these tumor models in mice. So we had a subcutaneous model with a SB1, which is a cell line, a cholangiocarcinoma cell line that I established in the lab and that has been validated. We also had orthotopic injections of SB1 as well as a plasmid-based model. Our first model, the subcutaneous model, we looked at treating mice with either a control, anti-PD-1 alone, anti-CD40, or the combination, and we see a delay in the tumor growth, which is demonstrated with the red dots, and interestingly also a significant survival benefit in this model. We looked at the same thing with the orthotopic model in which we injected these tumor
Lawrence, I'm sorry to interrupt. I just want to make sure that I don't see your slides advance.
Are you not seeing my slides?
Yeah, I still see in slide 4, and I just want to remind you that this is a 5-minute talk with 5 minute sessions.
Almost done.
Oh, good, perfect.
I don't know. Are you not seeing my slides now?
Advanced before, so just for everybody in the audience, you'll be able to go back and review this later.
Yeah, very sorry about that. I'm not sure why I'm moving forward with my slides. So briefly, yes, so the orthotopic model demonstrated the same benefits with much smaller tumors intrahepatically, and similar results with the plasmid model as well. And when we looked at, when we tried to examine the mechanism of action, we did see that there was a significant increase in hepatic immune cell populations within the livers of these mice treated with CD40 or the combination, and also an increase in the activation of these cells within the liver. And I'm not sure if you can see these slides, but hopefully you'll be able to go back and see them otherwise. And the final thing we wanted to look at was to see whether or not this combination enhanced the effects of cytotoxic chemotherapy. So we treated mice with cytotoxic chemotherapy and added CD40 and PD-1, and we saw a significant benefit both in a delay of tumor growth as well as in survival for mice treated with both cytotoxic chemotherapy and the combination of CD40 and anti-PD-1.
Just maybe if you're in presenter mode, it'd be easier for you to advance.
I am in presenter mode. I don't. I'm not too sure. Can you see my slides now?
We see your slides. It just wasn't advancing.
I'm not sure. I'm in slideshow mode.
Well, as I said, this is April Fool's Day, so you knew something was going to happen.
Indeed. Well, I'm sorry about that. But briefly, in conclusion, CD40 is highly expressed in cholangiocarcinoma, both in humans and in our mouse models, and the high expression of CD40 is associated with improved survival in patients with cholangiocarcinoma. Therefore, treatment with a CD40 agonist presents a novel approach to enhancing checkpoint blockade in murine cholangiocarcinoma. It drives the activation and replication and migration of immune cells, and it also enhances the efficacy of cytotoxic chemotherapy. And so there is a clear need for clinical evaluation of these benefits in patients. I just want to thank Dr. Gretton and everyone in his lab and everyone else at the NCI that I've had the chance of collaborating with. And again, I'm very sorry about the slides.
Yeah, thanks so much. apologize for the technical challenges, but really seems like very interesting work. So what are the next steps to bring this to the clinic, you think?
So actually, we are in the process of actually trying to establish a phase 2 clinical trial at the National Cancer Institute to look specifically at enhancing cytotoxic chemotherapy, which we know is not very effective. So in patients who have unresectable disease, treating them with a combination of cytotoxic chemotherapy and a CD40 agonist as well as a checkpoint inhibitor.
There's also a question about the murine model you selected.
Yes. So yeah, there were three models that we used. The first model was one in which we had cholangiocarcinoma cells that were injected subcutaneously, and we traced tumor growth over time. And once, for humane reasons, once the tumors had reached 2 centimeters in size or 20 millimeters in size, the mice were euthanized. So that's how we traced both survival and tumor growth over time. The second one was an orthotopic model, in which we injected the tumor cells directly into the left lobe of the liver, and we were able to trace their growth over time using imaging, and also we euthanized the mice at 4 weeks and compared tumor size. We also had an experiment where we allowed them to the tumors to grow until the mice died. And the third one was a plasmid-based tail vein plasmid-based model, and we used YAP and AKT plasmids, which we know create a cholangiocarcinoma within the liver. And we looked at the same thing at both tumor burden through immunohistochemical staining postmortem, as well as survival.
Well, thank you again for your presentation, and sorry for the challenges, but we're all looking forward to re-reviewing the slides. And we're going to move on, given the time. And we're going to invite Lipika Goyal to present her work on FGFR inhibition in intrahepatic cholangiocarcinoma. Welcome, Lipika.
Thank you very much, Funda. My name is Lipika Goyal, and I'm a medical oncologist at the MGH Cancer Center. I want to thank Dr. Bernstrom and Dr. Bridgewater and the organizing committee for selecting our abstract for an oral presentation. And I wanted to, on behalf of my co-investigators, present the data for the phase 2 trial, Phoenix CCA2, of the FGFR inhibitor Futibatineb in patients with intrahepatic cholangiocarcinoma harboring an FGFR2 fusion or rearrangement. This is the interim analysis. These are my disclosures. So as we all know, cholangiocarcinoma is an aggressive disease of the bile ducts, and we need more treatments. FGFR2 fusions have been shown to be oncogenic drivers, and they're seen in 13 to 14% of iCCA tumors. And last year in 2020, there was a landmark moment in the field of cholangiocarcinoma when pemigatinib, a reversible FGFR inhibitor, was FDA approved for the treatment of advanced and metastatic refractory cholangiocarcinoma harboring an FGFR2 fusion or rearrangement. This presentation is on Futibatineb, a highly selective, potent, irreversible inhibitor of all 4 of the FGFR isoforms. And it's a little different than the other FGFR inhibitors because it covalently binds to the FGFR kinase domain. And due to its unique mechanism, it has shown robust activity against FGFR2 kinase domain mutations that are resistant to the ATP competitive inhibitors. In a phase 1 trial, Futibatineb showed preliminary efficacy and safety, and based on the robust activity in patients with cholangiocarcinoma, this registrational phase 2 study was initiated. So this was a global study that enrolled 103 patients across 36 international sites. The eligibility criteria included having unresectable or metastatic intrahepatic cholangiocarcinoma, having an FGFR2 fusion or rearrangement, prior gemcitabine and platinum-based chemotherapy, and no prior treatment with an FGFR inhibitor. Patients were treated with this oral drug, Futibatineb, 20 milligrams orally, continuously in 21-day cycles. The primary endpoint was objective response rate by independent central review. This is the interim analysis presentation of 67 patients, and the median follow-up was 11.4 months. These are the baseline demographics, quite standard for a trial in patients with FGFR fusion or rearrangement positive cholangiocarcinoma, a slight female predominance. And in this trial, more than 50% of patients had 2 or more lines of prior therapy, so a heavily pretreated population. This is the primary endpoint, objective response rate by independent central review. As you can see, the ORR was 37.3%. 24 patients had a partial response, 1 patient had a complete response. As you can see, even in patients with stable disease, 28 of 30 patients had tumor shrinkage, and a disease control rate was 82.1%. The responses were durable, with a median duration of response of 8.3 months, and they also happened early. The median time to response was 2.5 months. Here's the progression-free survival data. Again, the median follow-up was 11.4 months, and the median PFS was 7.2 months. 37% of patients were still ongoing on the trial at the time of data lock, and so these data are expected to mature. Here is the subgroup analysis. It's a little bit of a busy slide, but if you look at the third column, that's the overall response rate. And you can see, regardless of baseline characteristic, people had objective responses, and it was quite consistent with the overall general population in this trial. And specifically, patients who had multiple prior lines of therapy still had a robust response rate. The co-mutation subgroup analysis will be presented at AACR next week. The safety profile of Futibatineb was similar to what's seen with other FGFR inhibitors. The most common side effect was hyperphosphatemia. The grade 3 hyperphosphatemia in patients who had that resolved in a median of 6 days, and no patients stopped drug permanently because of hyperphosphatemia. The other common side effects were diarrhea and dry mouth. Overall, 57% of patients had a grade 3 treatment-related adverse event, and no one reported a grade 4 or grade 5 event. Only 1 patient permanently discontinued from the trial because of a treatment-related adverse event, and this was stomatitis, some oral dysesthesia, and pharyngeal inflammation. Here are the adverse events of special interest. We talked about hyperphosphatemia already. 2 other ones that were relatively common were nail toxicities and eye disorders. As you can see, they were almost all grade 1 and 2 in severity, and specifically central serous retinopathy was seen in 9% of patients, and these were all grade 1 and 2 in severity. This trial is one of the first among the FGFR inhibitor trials to report on patient quality of life data. And as you can see, the functional status and the individual symptom measures were stable throughout this trial and through 9 months of the trial. So this was very encouraging that Futibatineb did not significantly compromise patients' quality of life. So in conclusion, Futibatineb showed good safety profile and preliminary good efficacy with a response rate of 37% and durable responses. This presents another good option for our patients with FGFR2 fusion or rearrangement positive cholangiocarcinoma. And the updated results are going to be presented at AACR 2021 next week on April 11th. I want to first and foremost thank all the families and patients who made this trial possible, and also my co-investigators. And I thank you all for listening, and I hope you enjoy the rest of your conference.
Thank you, Ludwika, for that great presentation. So you got a very hard question in the chat. The question was, how do you compare Pemigatinib with, what you're presenting?
That's a great question. It's what everybody is asking, certainly. They haven't been compared head-to-head. What we can see from the response rate data, it's very similar, the 2 drugs, and, the populations also were rather similar. In the Futibatineb study, it was only intrahepatic cholangiocarcinoma. Pemigatinib was intrahepatic and extrahepatic cholangiocarcinoma, but of course, the vast majority of FGFR2 fusions are seen in intrahepatic. But, when you look at the efficacy data, of course, there are issues with cross-trial comparison, but the data are very similar. The mechanism of the drugs is a little bit different. And, there's a little bit more hyperphosphatemia that was seen in the Futibatineb study. This might in part be due to the fact that Futibatineb is dosed continuously without any breaks. And also the definition of hyperphosphatemia was a little bit different. It was just based on laboratory values because hyperphosphatemia was not in the CTCAE version 4.03. It's now in 5.0. But in other trials, it was also based on symptoms and need for hospitalization. So that's why the definitions were a little bit different. But overall, very similar drugs.
Yeah. Another question that came in, in the genomics session, they had talked about the elegant work you previously have done with the cfDNA in demonstrating the acquired resistance mutations. The question was whether FGFR mutations were tested in this setting and whether you do that in your own practice.
Yeah, so the company did build in ctDNA evaluation at progression, and those results are going to be presented at a future Congress or manuscript. And yes, at Mass General, we very much are studying resistance in FGFR positive cholangiocarcinoma. So we have done some serial ctDNA testing in these patients. We presented some of that data at the Triple Conference in the fall last year. And we are collaborating with a series of different institutions around the country to put together, a robust landscape on what's happening with FGFR resistance, so we can help figure out what is the way we should be sequencing these tumors, what are strategies to overcome resistance. So it's certainly a team effort to understand resistance in FGFR.
Perfect. I think this flows in well with our next speaker. So thank you again, Lipika, for your great presentation. I'd like to invite Pashtun Kasi from University of Iowa, and he'll be talking about longitudinal monitoring of actionable somatic alterations.
Thank you for the opportunity. And again, thank you to the Cholangiocarcinoma Foundation for allowing us to present our results. As it builds upon the talk from Dr. Goyal about the value of circulating tumor DNA, cfDNA in patients with cholangiocarcinoma, I'll walk you through our key results in terms of doing NGS-based profiling. And in this case, we use the Tempus platform. In terms of what we did differently, at least in this analysis, is we really zoned in into what we called actionable aberrations for the sake of this particular study. And when I say actionable, these are actual drugs for which there is an FDA approval, for example, for the FGFR fusion, Futibatineb, MSI high for immunotherapy, or at least there is guideline endorsement or near approval, like for IDH1 mutations, HER2. There were nice presentations early this morning, the BRAF, the dabrafenib trial. So at least something for which there is an endorsement in the guidelines, or at least there is some sort of a trial readily available. That's what we wanted to kind of focus on as to how many of patients end up with truly actionable aberrations. And if indeed they have it, what is going on with them in terms of their journey, in terms of serial testing and longitudinal monitoring, focusing on the actionable aberrations, getting targeted therapy. And here's the first set of results. So, what's intriguing, we always keep talking about cholangiocarcinoma as a target-rich disease. As you can see in the table and also the bar charts here, at least a third of the patients had the select group of actionable aberrations as noted here. The other thing intriguing, again, there's probably a selection bias, but the ctDNA actually was able to pick up FGFR fusions, which often we think that large gene rearrangements may be missed on cfDNA, and that is probably true in a head-to-head comparison when you have tissue generous amount in both in the same patient, both solid and NGS as well as liquid. But in a real-world population, often cholangiocarcinoma is one disease where tissue is often not sufficient. So it's not surprising that cfDNA actually picked up more in terms of numbers, so actually it can increase the denominator of patients that can be identified for these FDA-approved drugs or trials. In the patients that we had a series who had FGFR fusions, again, and this is not the first time, but decrease in the VAF or ctDNA correlated with the response and the rise with progression. And more intriguingly, in the ctDNA, there were point mutation or gatekeeper mutations arising post-FGFR inhibitor therapy, as shown here in these three patients. And the other thing that's kind of building upon some of the work from our colorectal colleagues looking at anti-GFR, some of these aberrations decay over time. So in the earlier talks, there was a nice discussion about how do we sequence these different FGFR drugs, or for that matter, even going back to kind of quote-unquote recycling or rechallenging some of the same drugs that have already been used, depending on if these aberrations are present, and if building upon Dr. Goyal's work about the fact that some of these aberrations are maybe resistant to one, but may still offer confer sensitivity to another one. In a patient with ERBB2 amplification, HER2 amplification, responding to pertuzumab, trastuzumab therapy, we also found similar results. And again, a few months before the progression, gatekeeper mutations and other mechanisms resistance did emerge and were detectable on cfDNA. For IDH 1 and 2, there were good discussions earlier about the isotype switching that can happen, and we found similar results. And also in BRAF, again, exposure to BRAF/trametinib correlated with a response, and in a patient with ERF1 aberration getting alartinib, BRAF V600 actually emerged as an acquired mechanisms of resistance to EGFR blockade. So not only helping in identifying aberrations and looking at response over time, but also identifying potentially actionable aberrations depending on what we find. So in summary, our data, again, builds upon the elegant work already through some institutions on the use of liquid biopsy, cfDNA, ctDNA, and picking up actionable aberrations, not only just for response assessment, but also looking at acquired mechanisms of resistance. And also intriguingly, keeping the selection bias in mind, it can increase the denominator of patients who would benefit from targeted therapy, because right now, at least most of the ongoing trials only accept tissue-based NGS as an enrollment criteria, including some of the FDA approvals. Looking at the good specificity, so when you do find these aberrations, they are indeed very specific. So if you have a FGFR fusion detected on a cfDNA, that is less of a question. The question is if you're missing something else, if that is not detected. In those situations, it may not be a bad idea to already revisit the enrollment and allowing patients with cfDNA results to go on to these trials as well. Again, with that, I'll stop and look forward to the discussion on the topic. And again, my email and Twitter handle is listed. I would love to continue the discussion online.
Thank you for that really great presentation. This is a very exciting area with a lot of research, and I think we're going to start seeing more and more clinical utility. The way you framed it, it sounded like you thought that liquid biopsies had an advantage in identifying actionable alterations compared to tissue in a patient where you have tumor, where you can do sequencing or you can get a biopsy. Do you think that's the preferable approach, or liquid biopsy is the preferable approach for the initial molecular characterization?
You bring up a very intriguing practical real-world scenario, because often that has been the approach where you order tissue-based NGS testing, and let's say if you get a pathology or your commercial provider calling that the slides were not sufficient or you need more tissue, often individuals would reflex to maybe ordering a liquid biopsy at that time. Less often, one would proceed another tissue NGS-based testing. But what is also happening in parallel is often, both from a patient standpoint, also from a provider standpoint, there is an urgency or need to start treatment. And when you start somebody on treatment already, what happens, at least from a circulating tumor DNA standpoint, is because the half-life is only a few hours to maybe a few days, there is rapid decrease of circulating tumor DNA. So then you'll end up with a false negative result or a result that's not meaningful. So timing is key. As long as somebody hasn't started treatment, that is true. But at the same time, looking at the turnaround, some of the studies are estimating turnaround minimum 2, 4, 6 weeks. There was a nice study from Japan at ASCO looking at both tissue and liquid, and it was interesting. Again, tissue resulted in actionable result report 80% of the time. Liquid was almost 29% of the time. It kind of reflects that in biliary cancers, pancreas cancers being the same, often when tissue is not sufficient, the number of patients where you don't get a report can be to a third of the patients.
Okay, and another question that came in the chat, and frankly has been brought up a lot yesterday as well, was how frequently cfDNA testing should be done. Is this something that you think should be standard of care during treatment, or is it something that you should be done in patients who've gotten targeted therapy upon progression?
I agree with your latter statement. I think the real value of at least longitudinal monitoring or serial ctDNA analysis, not just for cholangio, but I would say any tumor type, is more so when they're getting a targeted therapy. That's where you want to see if there are secondary mechanisms of resistance or other new findings for which you might find a trial. There are ongoing trials looking at post-FGFR resistant clones and other FGFR inhibitors. On chemotherapy, I don't see its value for it to be repeated. And also, if you're considering quote-unquote re-challenge or maybe another target therapy trial, it's not unreasonable to repeat a liquid biopsy at that point in time, or in the first instance you mentioned, if you didn't have a meaningful report to begin with. But on chemotherapy, I see little value of repeat ctDNA testing, and also I think it's not cost effective. But on targeted therapy or any of these novel therapies, I think that's where its value would probably lie.
Yeah. Another clarification is about FGFR fusion testing in tissue as well as in liquid biopsies.
Yeah, so that builds upon the ongoing work reflecting, at least for fusions, often DNA testing may or may not be enough, and that's where RNA and some of the other platforms would at least increase the denominator of identifying most, if not all, of the fusions they are not missed. I think it's important to know your platform. We've had patients where they had tested through one platform, which didn't pick up a fusion consistently throughout their journey, but another platform was able to pick. And if you look at in the appendix as to what partners are they able to identify, I think the same goes for NTRK fusions. We know about many partners for FGFR2. So knowing the assay is of value because different providers, different places in the country may be using different platforms, including some of the academic institutions now ordering in platforms. So one should not assume that whatever assay you're ordering will cover the gene, especially when it comes to large genes like BRCA or DNA repair, or for that matter, fusions.
Thank you so much.
Again, thank you for the opportunity.
Okay, excellent session. Next, we have 4 speakers from MD Anderson, and the first speaker is Bradford Kim, who will be presenting an oral talk on oncologic quality metrics for biliary tract cancer surgery, differential performance by approach. Bradford.
Thank you very much for the introduction, and thank you to the Foundation for having this great conference and for allowing me to present our work here at MD Anderson. I have no financial disclosures. In the modern era of hepatobiliary surgery, the use of MIS approaches with laparoscopic and robotic-assisted technologies is becoming more commonplace for oncologic resections. Currently, there is a paucity of data reported on the quality of oncologic resection achieved with laparoscopic and robotic-assisted approaches in the treatment of biliary tract cancers. The AJCC guidelines emphasize the importance of an R0 resection and recommend performance of lymphadenectomy of at least 6 lymph nodes. The objective of this study was to assess the quality of oncologic resection for patients who required hepatectomy for the treatment of intrahepatic cholangiocarcinoma, intrahepatic cholangiocarcinoma and gallbladder cancer in this developing era of MIS surgery. So in order to do this, we did a retrospective cohort study utilizing the NCDB. This is a prospectively collected hospital cancer registry of over 1,500 centers in the United States. We identified all patients with intrahepatic cholangiocarcinoma and T1B or more advanced gallbladder cancers to isolate a single type of cancer operation, specifically hepatectomy with or without lymphadenectomy. We excluded mid-bile duct tumors and distal bile duct tumors as they require a different type of operation. High-volume MIS hepatectomy centers were defined as hospitals that performed a median of greater than 5 MIS hepatectomies, robotic or laparoscopic, per year for biliary tract cancers, representing the top 5% of all hospitals based on MIS volume. Primary outcomes of the study were surgical oncologic metrics, including R0 resection, receipt of lymphadenectomy, and retrieval of 6 lymph nodes or more. The total cohort included 8,612 patients, of which 40% underwent resection with an MIS approach. Overall, for results, the hospital length of stay was longest for open approach and shortest for MIS approaches. Overall, the 3 approaches achieved similar rates of R0 resection despite open resection being performed for more advanced tumors. At low volume MIS centers, the laparoscopic approach was least likely to achieve R0 resection. This is improved at high volume MIS centers. Independent predictors of R0 resection included academic facility type, clinically no negative disease, and a robotic approach, while advanced clinical T-stage predicted margin positive resection. Next, we found that surgeons failed to perform regional lymphadenectomy in a high number of cases, regardless of approach, although this metric was least likely achieved with the laparoscopic approach, where only 42% patients underwent nodal evaluation. The difference was especially pronounced at low-volume MIS centers. Achievement of this metric was ameliorated at high-volume MIS centers for both the open and laparoscopic approaches. Independent predictors of lymphadenectomy included high-volume MIS centers, academic facilities, and clinically node-positive disease. Advancing comorbidities and laparoscopy were factors associated with patients not receiving lymphadenectomy. When lymphadenectomy was performed, a guideline-concordant lymphadenectomy of 6 lymph nodes or more was infrequently achieved with all operative approaches. Although the laparoscopic approach was least likely to meet this metric, this rate improved when performed at a high-volume MIS hepatectomy facility, as was performance via an open approach. A multivariable analysis, clinical T4 tumors, high-volume MIS centers, and academic facility types were independent predictors of guideline-concordant lymphadenectomy of 6 lymph nodes or more. The laparoscopic approach is the most prominent factor in not obtaining a guideline-concordant lymphadenectomy. So in summary, obtaining an R0 resection was similar across all operative approaches overall within the NCDB. Regardless of approach, lymphadenectomy is underperformed nationwide in the United States, and it's least performed with a laparoscopic approach. When it is performed, the laparoscopic approach is again the most inferior in obtaining guideline-concordant lymphadenectomy. And our findings indicate that a sizable deficiency in the performance of lymphadenectomy, regardless of approach, and suggest that laparoscopy may be inferior in achieving appropriate oncologic resection outcomes, especially when performed in low-volume centers. Further, quality improvement initiatives are imperative to rectify these deficiencies, and dedicated MIS training should be considered when considering a MIS approach to these complex cases. Thank you for the opportunity to present our work here.
Thank you very much, Bradford, for being perfectly on time. Could you say a little bit about how you have taken into account WHO ICD classification for these tumor cases, considering some of the issues that has been between ICD-10 and 11 classification for particularly the cholangiocarcinoma cases?
Sure. We looked very carefully at the ICD codes, and we looked at and focused on only ICD-10 11 who were truly adenocarcinoma or biliary tract tumors, and excluded cases that were ambiguous for the pathology. So we took quite some time to look through all the codes to be very sure that the diagnosis was as clear as possible and excluded those patients that were in, and that will be included in the manuscript.
Yeah, great, thank you. You should probably also talk to Reses Benares about our European network registry of intrahepatic cholangiocarcinoma and try to see if there's any information that links with the European cases between.
That'd be fantastic. Yeah.
Good. Well, there is no other questions, so we will move on to the next speaker. Thank you, Bradford, very much for a great talk. The next speaker is from Meredith Mason, the first place award winner. Congratulations on that. She'll be talking about time to rethink upfront surgery for resectable intrahepatic cholangiocarcinoma, implications from the neoadjuvant experience.
Good afternoon. Thank you very much for the opportunity to present our work. I have no financial disclosures. So intrahepatic cholangiocarcinoma is the second most common primary hepatic malignancy with a dismal 5-year overall survival rate. Currently, surgical resection is considered an integral component of potentially curative treatment. However, survival remains poor in large part due to high rate of tumor recurrence and distant metastasis. Neoadjuvant therapy, including chemo and radiation therapy, are a standard part of treatment in many GI malignancies, but its use in intrahepatic cholangiocarcinoma is not considered part of the standard management strategy for resectable disease. Despite some encouraging results in unresectable patients, the role of neoadjuvant therapy for upfront resectable intrahepatic cholangiocarcinoma remains unclear. Therefore, the goals of our study were to describe current national trends in neoadjuvant therapy utilization, to examine factors associated with administration of neoadjuvant therapy, and to evaluate survival outcomes of IHC patients who received neoadjuvant therapy followed by surgery compared to patients who received upfront surgery alone for resectable disease. So this was a retrospective cohort study using the National Cancer Database from 2006 to 2016. Surgically resected patients with IHC who were at least 18 years of age and had stages 1 through 3 disease were included. The principal variable of interest was receipt of neoadjuvant therapy ahead of surgery, which we then stratified into single-agent chemo, multi-agent chemo, and any regimen that included radiation. And the primary outcome of the study was overall survival. Standard statistics were used to describe the overall trends in neoadjuvant therapy over time. Multivariable hierarchical logistic regression models were used to evaluate factors associated with the receipt of neoadjuvant therapy. Propensity score matching in a 1-to-1 ratio to match patients who received upfront surgery to those who received neoadjuvant therapy, as well as inverse probability of treatment weighting were performed to ensure robust results. And finally, Cox shared frailty modeling was used to examine the association of neoadjuvant therapy with risk of death. The overall analytic cohort included 4,468 patients, 607 of whom received neoadjuvant therapy ahead of their surgical resection. Patients who received neoadjuvant therapy in the overall cohort tended to be younger and more frequently had clinically node-positive disease. After 1-to-1 propensity matching, patients were evenly matched across all variables, with 516 patients in each group. The details of neoadjuvant treatment regimens are shown, with the majority of patients having received multi-agent chemotherapy as their neoadjuvant regimen. Between 2006 and 2016, when stratified by neoadjuvant regimen, multi-agent chemotherapy was the only regimen to increase over time, with 26% in 2006 and 68% in 2016. Single-agent chemotherapy significantly decreased over that same time period. When we looked at the same type of trends but in the adjuvant setting, we found the trends were similar to neoadjuvant, with multi-agent adjuvant chemotherapy being the only regimen to significantly increase over time, with 23% in 2006 up to 44% in 2016. Significant factors associated with receipt of neoadjuvant therapy are shown. Older patients compared to younger patients and Black patients relative to white patients had significantly lower odds of receiving neoadjuvant therapy. However, as you might expect, patients with clinically node-positive disease relative to node-negative and patients with higher T stage relative to T1 tumors had significantly higher odds of receiving neoadjuvant therapy ahead of resection. Among the propensity-matched patients, those who received neoadjuvant therapy demonstrated significantly higher unadjusted 5-year overall survival of 37% compared to 30% in those who had upfront surgery. After multivariate Cox shared frailty modeling in the propensity-matched cohort, neoadjuvant therapy was associated with a 23% significantly lower risk of death compared to upfront surgery. Results were also significant after inverse probability of treatment weighting. Several additional sensitivity analyses were also performed and yielded generally similar results, with patients who received neoadjuvant therapy having a significantly decreased risk of death in the overall unmatched cohort among clinically node-negative patients and among patients with T3 and T2 tumors. These results again remained consistent when we stratified by neoadjuvant treatment regimen. In conclusion, neoadjuvant therapy is utilized with increasing frequency in treatment of intrahepatic cholangiocarcinoma and seems to be driven by factors suggesting more aggressive tumor biology. Neoadjuvant therapy is associated with decreased risk of death compared to upfront surgery for resectable disease after robust modeling. Future prospective research studies are needed to better inform treatment guidelines on the use of neoadjuvant therapy for surgically resectable intrahepatic cholangiocarcinoma. Thank you very much for your attention. I'm happy to take any questions.
Thank you very much, Meredith. I have one question regarding the resection margin of these cases. Do you know anything about that? Are they R0 or R1? What proportion are they? And since you looked at overall survival, what about the recurrence-free survival?
Great question. We actually found the resection margins to be similar between the patients that received upfront surgery and those that received neoadjuvant therapy. With regards to the second part of your question about recurrence-free survival, unfortunately, with the National Cancer Database, we don't have that data. It's one of the drawbacks to using that particular data set, and so that's why we focused on overall survival instead. But that would be obviously a great thing to look at in the future and prospectively for sure.
Great, thank you. There is no other questions, so thank you, Meredith, for sharing your exciting presentation. I'm sure people might be sending you questions if there is any in the future while they look through the slides.
Thank you so much.
The next presenter is Subram Pat, and he will be presenting results from the phase 1 study of Zanidatamab in H2 expressing biliary tract cancers, design of Horizon BTC01 phase 2 study.
Thank you so much to the organizers for this very exciting opportunity. I'm glad I'm not the only one who finds the name a little bit hard to say. So I'm going to present today the results from the phase 1 study of Zanidatamab. I'm going to call it ZW25, its original name for the purposes of this presentation, in HER2 new expressing biliary tract cancers and design of the Horizon BTC01 phase 2 study. So I want to thank all my collaborators who participated in the trial. So as a background, we know that biliary tract cancers, including cholangiocarcinomas, gallbladder cancers, again, are aggressive rare tumors. We've seen that again and again. The treatment options for locally advanced or metastatic BTC is limited after the first-line therapy. From the published data and the presented data, we know that second-line chemotherapy yields a response rate of less than 10%, and median overall survival is very modest, as about 6 months. Again, interestingly, for targeted therapy, which really cholangiocarcinoma is one of the front runners in this, about 19% of gallbladder cancers, 17% extrahepatic, and 5% of intrahepatic cholangiocarcinomas do express HER2 new, or the human epidermal growth factor receptor 2. ZW25 is a novel HER2 new targeted bispecific antibody. So it essentially joins in one area where trastuzumab joined and the other area where pertuzumab joins, which is being evaluated in multiple global clinical trials, including one of our registration enabling phase 2 study, the Horizon BTC01, in patients with biliary tract cancers. So this is a kind of a cartoon of the ZW25. As you can see, there are two domains, the ECD4, which is targeted by trastuzumab, and the ECD2 targeted by pertuzumab. Again, this drug has a unique structure which really allows the improved binding and clustering and receptor internalization and downregulation. So very interesting and exciting drug. Now, this was a phase 1 study that I'm presenting right now, ZW25101. This was in HER2 expressing cancers. The key eligibility criteria were that the patients needed to have advanced HER2 expressing cancers with progression after standard of care therapy. I'm going to show you the BTC subset, who were treated. Again, this was a dose escalation study, then an expansion study, and I'm going to show you the BTC patients who were treated at the recommended phase 2 dose of 20 milligram per kilogram every other week, so Q2 weeks. So again, this is just the study design, 3+3 standard phase 1 design, and the phase 2 expansion cohorts were HER2 expressing breast cancer, HER2 expressing gastroesophageal cancer, and other HER2 expressing cancers. Again, BTC fell into that category. In part 2 that we are going to talk about, 21 patients with biliary tract cancers. Again, as we know, this is more percentage in gallbladder cancers. 12 of these patients with gallbladder cancer, 5 had intrahepatic cholangiocarcinoma, and 4 had extrahepatic cholangiocarcinoma, were treated at 20 milligram per kilogram. As you can see, the median age 42 to 78, about 67% were female. Majority had an ECOG 1 and a minority had an ECOG 0 on the study. Safety-wise, ZW25 was well tolerated. It's an outpatient monotherapy. We did not see any treatment-related grade 3 or higher events in BTC patients. There was one kind of serious AE of grade 2 fatigue in 1 BTC patients, and 2 deaths were reported during the study, 1 due to progressive disease and 1 due to unrelated AE. This is the waterfall plot of efficacy. And again, as we know, anything above the plot is progression. Anything below is stable disease or response. Again, it varies from 30% reduction to 20% increase. But I think we all can argue that anything that goes below is better than going up. So, this was a waterfall plot in which majority of the patients had either response or had stable disease with a decrease in their sum of the target lesions. And again, we did see some durable responses. So this is a swimmer's plot. This is for each patient. And as we can see, patients did receive durable response going into several months, with one patient achieving a durable response of more than 22 months. This is our response rate criteria. About 40% of patients had a partial response. Another 25% had stable disease for a disease control rate of about 65%, and the duration response was about 7.4 months. And one of the important points is that these patients were heavily pre-treated, so multiple lines of previous therapy before they received therapy with ZW25. So this was interesting, exciting data. Some of these were my patients also, and they did see an improvement. We did see an improvement in pain, which is a very important, I think, endpoint also as far as quality of life is concerned. So again, we looked at this data, and it was decided that the study supported further investigation of ZW25 in patients with BTC. So this is the trial that I'm very excited about, the Horizon BTC-01. It is a global phase 2b study of ZW25 monotherapy in HER2/neu amplified BTC. Again, this is a multi-center, all over the globe, open-label, single-arm study to evaluate the anti-tumor activity in monotherapy. We have the key eligibility criteria. You have to have histologically or cytologically confirmed BTC, including gallbladder, intrahepatic or extrahepatic cholangiocarcinomas. Again, these have to be locally advanced or metastatic, not eligible for curative resection, transplantation, or ablative therapies. Importantly, patients must have progressed after treatment with a gemcitabine-containing regimen. So not a frontline, more of after the frontline regimen. And again, patients must have experienced disease progression to the most recent prior therapy. And we are really we are doing in situ hybridization and IHC to evaluate these patients, and they should have an ECOG performance status of 0 or 1. So this is a very exciting trial, because I think development, it's very exciting to see the small subset of a rare cancer get this attention on a global scale. So this is our kind of overall cartoon of the design. This is for patients with HER2 amplified biliary tract cancers, about 100 patients, approximately 75. So we are doing both immunohistochemistry and in situ hybridization. So 75 will have IHC 2 or 3 for HER2/neu, and they would be ISH positive, or 25 with IHC 0 or +1, and they're also ISH positive. Again, our primary endpoint is overall response rate, with key secondary endpoints of duration response, disease control rate, progression-free survival, overall response rate by investigator assessment, overall survival. So very exciting trial, which is underway right now in multiple centers all around the globe. And this is the 9 countries which are participating currently. So truly global effort to move the needle in this disease. I'll conclude by saying that this drug, zanidatamab, was well tolerated and demonstrated promising early anti-tumor activity in patients with HER2/neu BTC that had progressed on prior therapies. And some of them were actually HER2/neu target agents. And after that, this drug was given. Again, it was well tolerated as a monotherapy with promising anti-tumor activity. And the pivotal global phase 2 trial that I talked about, Horizon BTC-01, is now open for enrollment. So I would encourage everybody with this amplification to consider this trial. And you can get this information on clinicaltrials.gov. And I really wanted to thank the patients and their family members who really help us every day in moving the needle in this disease. Thank you so much, and I'll stop right there. Thank you.
Thank you very much, Subhab. And yes, those names are very difficult. You can always stumble over them. So I do like ZW25. So the trial enrolls HER2 amplified cases, but HER2 can be overexpressed, as you started by saying. But through other mechanisms as well than amplification. So you have not considered including any that has overexpressing of HER2.
Yeah, so the trial essentially, thank you for that question. The trial essentially, what we do is we do central screening for them. So this could be a patient that is seen locally in the clinic, and they have, you do a local IHC and they're HER2 positive, and that's one of the, but we then centrally, we make sure that the patient, because we're looking at this as a registration trial, centrally they're being, we do a HER2 IHC and an ISH, the in situ hybridization, which allows the patient to come on the trial. And it's not only ones which are HER2 locally, but also the patients who are HER2, any tissue can be sent off and they can test it for HER2 essentially on these patients. So
good. And would you say that the HER2 testing should be standard of care for cholangiocarcinoma in the future?
Yeah, I think NGS should be a standard of care for all cholangiocarcinomas which show up, and in that we can see the HER2 amplification. I do think I'm a big proponent of because in my previous talk earlier in this day I showed some response rates in patients who were treated off protocol with other HER2 targeted agents, trastuzumab, pertuzumab, and other HER2 target agents. So I think any patient showing up should get an NGS, should get a HER2 IHC, and should get an MSI testing at the least.
I fully agree. And could you speculate if one of the reasons why TKIs in general have not had that great success in cholangiocarcinoma to date, at least, could that be due to other kinase pathways, what we sometimes call oncogenic addiction to receptor tyrosine kinases, at the same time as they have an overexpression of HER2? Do you consider testing for this as a resistance mechanism, for example?
Yeah, so on all these, that's a great question. So on all these, we are doing, again, this is some of the correlatives and everything, NGS, so we should have more information on this. I think a lot of it depends on the drug, what kind of, what the mechanism of action of the drug is, the blocking, how it's, the effectiveness. And you're right, these other oncogenic pathways, let's say in some ampullaries can have HER2 and KRAS, and that's, that's definitely, would be challenging for this drug. So this is only for cholangiocarcinomas, but you're right. That's why some of these, the populations have been very heterogeneous. Again, the amplification. So I think this is a good way through a clinical trial to really parse out a population which will get, potentially get benefit from HER2 targeted therapies. So I think that's very important. If you have to have the nail has to be right for the hammer. Essentially, that means we have to, when we're trying to crush the cancer cell, we really need to know we're hitting at the right place. So I think that's very important.
So you're thinking about some next step clinical trials to run with this drug or other drugs in this family with potentially KRAS inhibitors in combination?
Yeah, right now we'll see how this goes. This will be a kind of a good population, see how the enrollment goes and everything. But really, we should get good data from this trial to further some other more complicated questions along the way.
And you got another question. So do you see in the future that cholangiocarcinoma will be like breast cancer, where there will be many different HER2 targeting agents coming along, even though in the past drugs have failed in that space?
Yeah, so I always am a proponent of more drugs in cholangiocarcinoma, but I think the reality is it is a rare tumor. So I think we're excited about trials like this that we can do, that we can actually potentially register drugs in this setting. I think it'll be challenging to have more than a few drugs registered in this setting just because of the small percentage of patients who are there versus breast cancer, which is a bigger population in the US and all around the world.
So have you thought about including other patients in the biliary tract system, like ampulla or gallbladder cancers into this, like they have done in the ABC08 trial to broaden the number of patients that you can include?
Yeah, I think the ampullary, what we run into is also they can have, a lot of them can have KRAS mutations, and we know the history of some of these drugs, and especially in colorectal cancer, when it's there, these drugs do not work as effectively. So that was one of the thoughts essentially. And the second thing is, yeah, there are kind of anti-HER2 therapies in the frontline setting in BTC coming up. We do think, the trial is underway, and, with everybody's commitment and with everybody's, when we get enough, hopefully sites up and running and get accrual, I don't think that should be a bigger issue of enrolling it. But we have to be cautious. I think Ghassan showed earlier on in the day of the FGFR inhibitors that those trials can take up to 2040 to accrue. So we just have to be a little careful and how many drugs we really do, go into this setting for a rarer population in that setting. So but that's a more philosophical question than overall question. So, but hopefully, I'm hoping that we should have enough patients who would be able to accrue to this trial with the global nature of it, and it's about 100 patients. So hopefully we should be able to. The effort is underway, so hopefully we should be able to get it accrued soon. So with everybody's support, so we appreciate it.
Very good. Thank you, Shoaib, and good luck with the trial and recruitment. We will move on to the next speaker, that's Ahmed S. Shalabi, and he will be presenting all talk on the potential resistance mechanism of FGFR inhibitors in FGFR2 rearranged cholangiocarcinoma.
Good afternoon. My name is Ahmed Shalabi. I'm a research fellow at GI Medical Oncology at MD Anderson. I'm presenting on behalf of MD Anderson and colleagues at Foundation Medicine. Our presentation is on potential resistant mechanism to FGFR inhibitors in FGFR2 rearranged cholangiocarcinoma. Here are our disclosures. So in FGFR2 rearranged cholangiocarcinoma, resistant mutation in FGFR2 after treatment with FGFR inhibitors have been reported in case studies. We aim to further characterize potential FGFR2 resistant mutations and resistant mechanism in other driver genes. Additionally, in patients who are both FGFR2 rearranged and resistant mutation positive, we aim to identify actionable concurrent mutations alongside FGFR2. So we identified 932 patients from the Foundation Medicine database, which are cholangiocarcinoma or unknown primary harboring FGFR2 rearrangements, who might also as well be cholangiocarcinoma patients. Out of those 932 patients, 19 also harbored potential resistant mutation in the FGFR2 genes. Both tissue and liquid biopsies based next generation sequencing were able to detect FGFR2 rearrangement and resistant mutation. There's a really important point to note here that out of those 19 patients, 15 were from hepatobiliary source, and also we had 2 from metastatic and another 2 from liquid biopsies. So this pie chart here shows different fusion partners observed, and you can see that here that we have the pick one was 227 patients, and it was the most common partner. And we also had 458 patients that had unique fusion partners, and also the majority of the 112 that didn't have any fusion partner had identified truncating rearrangements. So the pie chart on the left here summarizes the diversity of FGFR2 resistant mutation observed across those 19 patients. And on the right side, you can see that the resistant mutations mapped to the FGFR2 rearrangement. Can see that most of them fall in the tyrosine kinase domain. Although we don't know what type of treatment those patients had, 17 of the 19 FGFR2 rearranged resistant mutation patients were tested in 2017 or later, and that reflects the ambient use of the FGFR2 inhibitors. So this is a really nice slide that we like here, and we were able to identify 7 patients who had FGFR2 resistant mutation and serial testing. And if you look here on the left, it shows the first original FGFR2 rearrangement, and the second test here is on the right that shows the emergence of the resistant mutation and also the original FGFR2 fusion that appeared on the first test. In 2 cases, the resistant mutation were detected by liquid biopsies, suggesting the utility of circulating DNA for serial evaluation of FGFR2 inhibitors. Our next slides further highlights patient 6. Right here. So our patient here was diagnosed at 37 years of age with intrahepatic cholangiocarcinoma. Foundation 1 testing of a recurrence that happened in 2017 showed that he had FGFR2 fusion. So the patient was enrolled in an FGFR inhibitor trial and received treatment for 10 months. And the patient then had resection followed by capecitabine. And a second recurrence happened in 2019. And it showed that a resistant mutation that did develop, which is FGFR2 in 5490, and also the original FGFR2 fusion. Patient was then treated by multi-target kinase inhibitor for 10 months, and he had ablation in 2020, but then unfortunately he had a third recurrence in March of this year, and there's planning for further ablation. So we identified a total of 39 patients with FGFR2 rearrangements who received serial next generation sequencing. And this graph highlights the altered genes that commonly emerge during serial testing. So in addition to the 7 previously discussed patients with FGFR2 resistant mutation, genomic alteration emerging during serial testing includes gene belonging to the homologous recombination pathway and also RAS and PI3K signal pathways. So in conclusion, in cholangiocarcinoma patients with FGFR2 rearrangements, FGFR2 point mutations can be detected in sequential biopsies and may account for resistance. Other potentially actionable concurrent mutations can also be detected and will require precise targeted therapies. And both tissue and liquid biopsies testing are able to identify potential resistant mutations. The utility of liquid biopsies for serial evaluation of FGFR inhibitor resistance should be further explored. Thank you.
Thank you very much, Ahmed. Do you know anything about the treatment history of the patients that were included in your study?
No, for the treatment, the thing about the slide number 7 that we have here, I'm not sure if I still can show it. So we don't know like what treatment did they have, but mostly we have FGFR inhibitors. Usually would have it like a first line of chemotherapy, and so the aim of this presentation is kind of to look of the importance and significance of having serial genomic testing. And the persistence of the original FGFR fusion and development of the resistance. This is regardless of, we did not look at any treatment. All we know that they had an FGFR inhibitors. It could be several of other trials that we have.
Yeah, it could of course be very interesting to know the treatment, if that causes any specific resistant mechanisms to occur during the treatment history. Also, during the different tests, well, actually the question is if there is any different tests being performed at the different time points, or is it the same test?
Yes. So there's also to note that with the 7 patients that we showcase, it goes all the way from a few weeks, few months to several years actually. And like the patient that we showcased, patient number 6, he was going strong for a 9-year history of intrahepatic cholangiocarcinoma, and the 2 tests that he had was 2 years apart. The first one was in 2017, the other one is in 2019, and it did actually show the original fusion rearrangement that showed up on the 2017 test.
Okay, and the most common one, FGFR BICC1 fusion, do you also see that in liquid biopsies, or is it only in the tissue biopsies that you see it?
Oh, that one, I'm not sure about the PIC one if it was shown in liquid biopsies.
But you do see fusions in the biopsy, right?
Yes,
in the liquid biopsies.
2 of the 7 patients actually did have liquid biopsies.
Yeah. And is there any difference if you stratify for the ones that you know are cholangiocarcinomas versus cancer of unknown primary?
I'm sorry, could you repeat that again?
You mentioned that cancers of unknown primary were included in this study because they could, with FGFR2 fusion rearrangements, of course, and they could therefore, because of the FGFR2 fusion, be a cholangiocarcinoma. But do you see any differences?
Yes, there's a possibility that the unknown primary one could be cholangiocarcinoma patients. We did not stratify the difference the different two groups. Between all we know, there's a group that has confirmed cholangiocarcinoma, another group that was unknown primary.
Okay. And do you think, what do you think is best, to repeat the tissue biopsy, or it's as good to use a liquid biopsy following the initial testing on the tumor tissue?
Well, the thing with liquid biopsy, it's always easy to obtain, and it offers a good opportunity to test patients who don't have insufficient tissue to run for tissue biopsies, or the feasibility of having another biopsy that's just only a blood test. For that, this question has to be more to the clinical scenario that you have. Is the patient, are we going to do a tissue biopsy, or are we going to do a liquid biopsy? But we kind of tend to see similar results between the two in terms of having serial testing.
And maybe I missed it, but regarding the resistance mechanisms, you talk about that in the FGFR fusions, we also know that mutations occur over time following treatment. But do you see any other more specific actionable mutations in other pathways coming up during the history of these patients?
Yes, we do see. Some of them have PI3K pathway, other develop RAF pathways, and even the one that have actionable mutations, the resistant mutation ones, also do fall. Most of them actually do fall in the tyrosine kinase domain.
Then you have one from the audience as well. From the FMI side, at times there are some notes included in path reports. However, we don't disclose those, and at times they mention only FGFRI, so FGFR inhibitors, and some had no information.
And from that is from the FMI side at times. That question I'm going to have to circle back to you about.
Yeah, I gather that it goes in line of the treatment history. Otherwise, the one in the audience may have to ask again. But you did disclose that you did not have the treatment history. Yeah. Besides that, do you have information of also from the audience? The person know that this is a talk about FGFR2 fusions, but did you see FGFR3 coming up in any of these reports?
Yeah, not in these patients, no, not in this cohort.
Okay, thank you very much, Ahmed, and for a great talk. And now I think that we will go back to Funda for a roundup.
I know. Thank you so much, Jesper. This is such a great session. Great talks, and I was very impressed with how most people were able to get their slides up and running as well. So, and we also had the fortune of finishing a few minutes early, so we'll be able to have a little bit of a break. So thanks everyone for your engagement and great questions, and enjoy the rest of the sessions.